Hello, everyone, and I hope you are all doing well in this critical times. I know most of the attendants are going to have the January exam. We hope you are, inshallah, doing very well in the exam, and it will be easy once you are all concentrating on the tips and tricks we are going to tell you in this session. Today is a very special one. Here I am, Dr. Muhammad Amin, speaking with you, and our examiner board. Most of them will be here today to share with you some final tips and tricks. Most of these tips and tricks based on our courses during January exam courses, which finished, and we finished all the activities a few days ago. So we prepared this session to share the most important issues that we faced with our colleagues during this preparation period. There are a lot of you are participating in the different courses in RADME, so we are to exposed with you to the weakness, the weak points, and we worked together along this time to fulfill the criteria of the exam, and tried very hardly and overcome all the problems we faced together. I want to thank everyone who shared his feedback with us. This will help us. It's very important, and it will help us to improve our courses toward for the coming exams, inshallah. I don't want to waste time. Firstly, and during this introduction, I want to thank all our examiner board here, and I will share this with you because they make a very hard work, really, in the private Viva course especially. It was fantastic. All the colleagues are happy with it. So I want to thank them all here in front of you before we start our activities, and also to give time to our colleagues to be with us during the session from the start. I will share the screen again to thank every one of our examiners with you, and it's a pleasure also for for the colleagues who will come in the coming courses to know them and personally. Okay, let me give me a second to share it. Okay. The share screen now again. Okay. Thank you, Dr. Awala. This is Dr. Awala Sakr. It will be with you today. It will share some cases with you. Thank you, Dr. Awala, for being with us. Thank you very much. Dr. Riham Muhammad Hussein, she is also with us in the a lot of courses. In fact, she is a very active member. Thank you very much, Dr. Riham. Dr. Riham, the problem with the case is not with you. It's just a joke. The head and neck cases, it's very tough in the exams. Thank you very much. Dr. Muhammad Fuad is a very kind friend and very helpful one. Thank you very much, Dr. Muhammad, and we hope the best and to see you again and again in the upcoming activities. Thank you very much, Dr. Muhammad. Dr. Tamer also is a very close friend to us all, me and Dr. Saeed and Dr. Rizq. Thank you, Dr. Tamer, for the attendance and for the commitment and very nice things you did for all the candidates. Thank you very much. Dr. Ahmed Al Hajar, this is a special relationship between me and Dr. Ahmed Al Hajar. Dr. Ahmed Al Hajar, one of the best teachers and the best instructors you will meet. He is a very kind and having a lot of the tips and tricks he will share today with you tonight. Dr. Ismail, this name I can't tell about him. You all know Dr. Ismail. So there is no much words to explain Dr. Ismail's efforts and his guidance to all the radiologists in the Middle East, especially. So thank you, Dr. Ismail, for being with us. And it was an honor for us to be with us during our activities. Thank you very much. Dr. Muhammad Fahmi, also he is a very intelligent and serious doctor you will face in the Viva. So you must be scary if you found him and if you find Dr. Muhammad Fahmi. He will simulate the exam. He will be like the examiner. So you will take a lot of tips and tricks with him today tonight. Also, thank you, Dr. Muhammad Fahmi, for being with us. Dr. Mustafa Al Hajar, and this is this one, Dr. Mustafa. We shared the success together. Dr. Mustafa is a close friend and kind man. Thank you, Dr. Mustafa, for being with us. In fact, the courses, the important thing regarding FRCR, it's a journey, and during this journey you meet and you already have a lot of friendship, which is very important in your life. Sometimes it's very helpful, and it will change a lot of your life. Before I leave the speaking to Dr. Mahmoud Al-Saidi, I want to share a very important tip and trick in the coming days for our colleagues who are going to have their activities during the next Friday, the first exam. You need now to prepare your mind and your soul for the exam. So relax and relax and relax. Stress is your enemy in this coming days and hours. Please fight it and be calm and relax. I will leave the session to Dr. Mahmoud Al-Saidi. A long time we are waiting for him, so he will be with you today, and he will arrange all the session. My mission ended here, and he will take it from here. Thank you, Dr. Mahmoud Al-Saidi, also for being with us. And thank you again to the back people in the back. They are not in the front of the screen. Bradney team, Isra and Ahmed, all of them, they are having a very miracle work. They are doing a lot of things that all the candidates with us know their work. Thank you all. Dr. Mahmoud Saeed with you. Thank you.
Hello, assalamu alaikum. Happy to meet you again, all of you. Thanks for the nice presentation from Dr. Muhammad. He did a great job really for establishing these courses and for the website itself. A very effortless work. I want to thank everyone again, and I want especially to thank Dr. Qasim. He is with us today. I saw him in the chat. He's a wonderful teacher. He helped us a lot while we were preparing for our exam. Thanks, Dr. Qasim. I will go to the important things now to start a quick revision for the exam. As all of you know, this is an exam. This a real workday exam. It is not anything else. Don't panic. Don't overestimate the exam itself. This is only exam. They will show you some cases. The cases are from your daily practice. The cases are for human beings. You always saw this kind of cases in your exam, in your day-to-day practice. So no need to fear anything. And all of you, I told you before, all of you know the important stuff, the basic information needed for this kind of exam. So relax and organize your thoughts and only present yourself. Uh, this is as simple as that. Each case in the exam is a small exam itself. Each case, you should put all of your effort and concentration to finish each case independently. And when you finish this case, you will go to another case. This is another exam, a new exam. If you did very well in the previous cases, you still should fear from the next case that it may have a red flag or emergency finding that you probably miss, and it will ruin all your previous cases. So please concentrate on each case independently. As you know, also the first day will be the reporting day for the long and rapid reporting cases. The second day is the Viva day. The first day is very important that you put one of your feet toward the success. You should score as much as you can from the first day. This is only your day. The marks in this exams, the rapid and longs, are only your effort. No no variations like in Viva, no variations between the examiners, no variations between the marking scheme. All of the cases in the long and reporting are solid facts. You should score right or long, normal or abnormal. You get the important findings in the long case or not getting it. So it is your effort only. So you should get very high marks as much as you can. All of all of our colleagues before also score in the first day, especially around 13 or 14 marks. So give you much more space to relax in the Viva day. For the rapid reporting cases, I had I had a presentation on the YouTube channel, and I showed it many times for you before, and it is very important for the rapid exams. Again and again, I will not go through it again. You can watch it on the YouTube, but please be specific. Each view or each X-ray has a pattern, a search pattern or a scheme to go through it. If you don't have this search pattern, you will lose many marks in the exam, especially with the stress of the exam, and you are short in time and you are going in a hurry. Just a second, I will mute everybody. Okay. You should have a search pattern. You should have a scheme to go through the cases. If you saw a chest X-ray, so you know how to deal with the chest X-ray without thinking. I know I will look at this one thing first, and then this, and then that. Like, and you must have this scheme pattern, because you will lose your pace and you will lose your concentration inside the reporting exam, especially because it is very fast and only 35 minutes for 30 cases, and you are getting to the rapid reporting exam after the long. The long is very exhausting and a little bit more tough. So your concentration is way less than your normal concentration. If you don't have this solid approach, you will lose many marks. And each image you will see, oh, this is normal or abnormal. This line is a fracture or not fracture. Is there here a dislocation or not a dislocation? Is this a stone or not a stone? So you will go in very frustrating thoughts and flight of ideas during the exam itself, and there is no time for that. So you should prepare well for this part of the exam. This is the simple rules. You must know these simple rules, and you must go through it and use it in the exam. If you miss one single rule from this slide, you may lose marks in you may lose marks in the exam. So write only a definite abnormalities. They will bring only the definite ones, definite fractures, definite dislocations. You are searching only for the signs. You are not searching for any abnormal shape or any strange shape. You will not go through that. You only searching for signs. If you find an abnormality, you should write it down in the same pattern. The side right or left, the site, the exact site of the abnormality, and the sort, the type of abnormality. And you should put each part of the answer very clear, right? The site, and the sort. Again, I keep reminding you for this specific rules, each view and each age has its own checklist. Don't bring abnormality in adult and put it in pediatric X-ray and vice versa. If you have a shoulder X-ray, you must know the types of the shoulder X-rays. Each view of the shoulder X-rays has also its abnormalities. The AP view, the Y view, the axillary view, the glenohumeral view, each one has its abnormalities. And for the wrist and for the knee, all of the X-rays, you must know the view, and according to the view, you will choose the abnormalities accordingly. And don't forget the edge of the film. The edge of the film may contain abnormalities, but it must be clear. You must see a clear fracture. Both fracture ends are going overlapping each other, or you must see a clear fracture or a clear abnormality at the edge of the film. So if you didn't look at the edge of the film, you will not see it. But if you did look at the edge of the film, you definitely will find it. Okay. And the checklist for the rapid is way different from the Viva checklist. The Viva checklist is more detailed and more subtle. You can find in the Viva grade 1 Sufi, but you never will find it in the rapid reporting. You can find in the Viva more subtle soft tissue changes or more subtle vascular abnormalities or like that, but you never find it in the rapid reporting exam. So please separate them. Each set of the exam has its own set own mindset. Also, don't over zoom or don't over windowing the screen and like that, and be fast. Go through the cases very fast, as you are doing in your practice. If you're practicing that you finish the exam in 10 or 15 minutes and you will go to a second or third also run through all the cases, so do it in the exam. If you were practicing that you will do the exam only once and you are doing it very slow, so do it in the exam. Okay. Choose your answers from the RR answer box. 99% of the answers you will find it in this file. So please don't bring answers from your own and be a robot searching only for the signs. This is for the rapid reporting part, and this is a very important one. For the long reporting, they want you to get most of the findings. This is the most important part in the long reporting. You must get most of the signs. Even if you didn't get the right diagnosis, but you must get the most of the findings and try to combine all of them to a single cause or a single disease that have all of these patterns. For the long reporting also, don't forget to put a detailed management, not only referral to the referring physician. No, you must put down what will happen to this patient, what will happen to this case specifically, what kind of images the patient will need, what kinds of interventions the patient will have. You should put all of these details. For the differential part, the differential diagnosis part, also be specific. You are putting differential for this single case that you have its history, the patient age, and the findings. You are not putting the differential diagnosis from the books. You will not put 5 or 6 differential diagnoses. Only you can put 1 or 2 as maximum in the differential diagnosis part. For this patient age, for this images findings. Okay. Also, I want to advise you, calm down. Each case will have 10 minutes. It is theoretically, it is a short period of time, but really you can make it in 10 minutes because they don't want a full report or a complete report. They want only the core of the findings, the important findings and the associations and the most important 2 or 3 negative data, and how you will combine all of this and tailor them for a single diagnosis and what could be other possibilities for this diagnosis, other differentials, and what will happen to the patient. As simple as that. If you took around 2 minutes in the beginning to scan the exam from the first cut to the last cut and figure out what is the main abnormality here. It is a bowel obstruction, it is a malignancy, it is inflammatory, what kind of abnormality in this case. And then you will start by describing this main abnormality, what is happening here, what is the description for this specific abnormality, and what could be the associations of this abnormality, and what could be the complications of this abnormality if it is present or not. And then you, after that, after you complete the main picture or the main idea of the case, after that you can scroll down to see the rest of the exam and put down the negative data or the incidental findings, anything else, but put it after you finish the main idea or the main abnormality of the case. And then the interpretation will be a general idea, the heading, the title of this case, if you can find it in the books, what will be the title of this kind of disease, and then the specific diagnosis, and then the differential diagnosis, as I told you, only 1 or 2 that looks like to these findings or to your description or to this patient age specifically. And if you didn't find the differential diagnosis, you simply put no differential diagnosis and the management. Also, give me more 2 minutes or 3 minutes. I will finish now, but I want to tell you also about a very important thing in the VIVA exam, the non-contrast CT head. The non-contrast CT head is a very, very important and tough topic in the VIVA exam. Most of the times, they are bringing a very subtle CTs for the head, and most of them are emergency cases. And if you didn't tackle it in a good way, you will lose the whole VIVA exam. This room of the VIVA exam, you will lose all the marks because the emergency cases are very, very important. I have here 2 types of cases. I want to show it for you. This patient is coming in RTA, is presented by motor vehicle accident or road traffic accident. And if you hear this kind of history, so you should search for the important things that could happen from this kind of history. A trauma patient should have a very common injury or a very dangerous injury is the bleeding. Please mute. Sorry. Yeah. Okay. So the most important thing in RTA or road traffic accident cases is the bleeding, and you should have a search pattern. You should know where the bleeding will be. So you will go to search for the bleeding. You have many types of bleeding: the extradural one, the subdural one, the subarachnoid, the intraparenchymal, and each type of them has a common sites. So for the brain contusions, the most important areas for brain contusions are the uh, anterior temporal lobes bilaterally and the bases of the bifrontal lobes, and also for the along the tentorium. These are the most common areas for brain contusions. For the subdural, you can see it anywhere, but it may be very subtle along the falx or along the tentorium. For the extradural hemorrhages, you must have a overlying fracture in most of the cases. And the extradural ones are the very important point in them, that if there any mass effect causing caused by the extradural hemorrhage, is there any mass effect or not? Is there any active bleeding or not? So you must clarify these points if it is present or not present. Also for the subarachnoid hemorrhages, you are searching in the sulci, all the sulci and the ventricles, and don't forget to look for the basal cistern and the foramen magnum cistern also, because many times you can find bleeding there, and this is emergency, and you if you didn't find this kind of emergency, you will lose the whole viva room again. So for the emergency cases, be cautious. Another example also for the non-contrast CT brain is the history of the patient is not responding, or patient is loss of consciousness, or unresponsiveness, or Glasgow Coma Scale 3, or all these kind of histories are all linked to an ischemic brain injury. Most of time, this is the most common presentation of ischemic brain injuries. For the ischemic brain injuries, first you must know the subtle or the early findings for the brain infarction. All of us know the MCA, the famous MCA infarction pattern, the hyperdense vessel sign, but it must be hyperdense. Not all the vessels are hyperdense. Only this vessel thrombosed is more hyperdense. Also for the insular ribbon sign, and for the effacement of the overlying sulci, and after that losing the gray-white matter differentiation, all of this kind findings related to the specific arterial territory infarction. So the important or the more difficult one, if there is global ischemia, or if there is global hypoxia, like this case. So all the brain density are low, and all the gray-white matter differentiations are obscured, and most of the sulci are edematous and effaced. Also, you can find here the basal ganglia. It should be hyperdense. The normal basal ganglia should be hyperdense. Here it is hypodense. This is the reversal sign. So when the changes are very symmetric and very diffuse like that, you most probably, if you are not searching for it, you will not pick it, and you will miss this case also. So please, again, have a specific search pattern, and you should present yourself very well in the exam. This is the most important advice. for this kind of exam. Now we will go to the rest of our talented and experienced speakers and friends. We are glad to have all of them. I think we will start by Dr. Wala. You are ready?
Yes, Dr. Mahmoud, how are
Yeah, you can share the screen.
you? Okay.
Okay.
First, I would like to thank Dr. Muhammad Amin, Dr. Mahmoud Saidi, Dr. Mahmoud Reza, and all Red team. I would like to thank all candidate, and I hope all of you will pass, inshallah, the exam. I'd like to review some cases, important case for exam, common exam case, especially. I would like to review it with you. Many candidates missed it, so I would like to review it with you. First, this X-ray hand. This patient has a history of trauma from 6 months and presented with pain. The key finding here, there is periarticular osteopenia, mainly in the metacarpopharyngeal joint, in distal radiocarpal joint. Also, we can see here all the heel fracture. So first stability in this case.
Sorry, sorry, Dr. Wala, your voice is not clear. If you can raise your voice, it will be good. Thank you.
Okay. Okay now?
Okay, I think it's okay.
It's okay now?
Yes, go on.
This case, the patient presented with pain. He has history of trauma from 6 months. This common case in the exam. We see here the periarticular osteopenia in the carpopharyngeal joint. No evidence of bony erosion. Also, there is all heel fracture, distal radius. So first, different diagnosis, we would put reflex sympathetic dystrophy or pseudo atrophy. I'd like to recommend to do isotope bone scan. We can add different diagnoses, rheumatoid arthritis, but no evidence of bone erosion. The key here is fracture, all the fracture with periarticular osteopenia. When we do isotope scan, the examiner will give you the isotope scan. So there is increased uptake in the metacarpopharyngeal joint and distal radiocarpal joint. So this case is specific for reflex sympathetic dystrophy. It's a common case of the exam.
Sorry, Dr. Wala, I am so sorry for interrupting you again, but the voice is interrupted. And can you check your mic again, please? I'm sorry for that.
It's okay now? It's okay now, doctor?
Yes, it's okay, but keep it like this.
Okay.
Okay, thank you.
Start again from the start.
Yeah. It will be better. Okay, thank you.
I said this case is common in the exam cases. The patient presented with pain. He has history of trauma from 6 months. We can see now this periarticular osteopenia in the carpopharyngeal joint, in distal radius. This specific pattern is specific for reflex sympathetic dystrophy. I would like to do next step isotope scan. We can give different diagnosis rheumatoid arthritis, however, it's less likely as no evidence of bone erosion, which is common in intercarpal joint and metacarpal joint. No here bone erosion, only there is metacarpal osteopenia. Regarding this history, I would put first differential diagnosis, reflex sympathetic dystrophy. So next step, I would like to assess the isotope bone scan. The bone scan here is specific finding. There is uptake in the periarticular area, in the carpopharyngeal joint, in distal radius. So this case is common in the exam case. Don't forget it is reflex sympathetic dystrophy or pseudic atrophy. Another case here, just X-ray, so common also in the exam. Don't forget to be systematic in your approach. Here, if you don't find anything, you should look to lung pieces in both sides, in paratracheal area, in the hilum, in retrocardiac area, and blue diaphragm. We see here there is right paratracheal shadow. This right paratracheal shadow, my different diagnoses are lymph node, paratracheal lymph node, right side aortic arch versus bronchogenic cyst, because it has small border. So we should look to the other side. We cannot see the aortic knuckle here. So my top different diagnosis here is right side aortic arch. My next step is CT chest with contrast. This case is common also. We can see here in the hysterosalpingograph, there is multiple outpouching in the fallopian tube. It's a common exam case. This case is salpingitis eschimocanodosa as a result from chronic infection in the fallopian tube. Different diagnosed TB salpingitis. This common exam case and complication is ectopic pregnancy in this tube. This is the multiple diverticula in the tube. This also case common, maybe the examiner tell you that baby is 2 weeks or less than 1 month and present with vomiting. If baby was, in case of baby less than 1 month with vomiting, and we see here there is bowel dilatation, we cannot determine the small or large bowel because there is still baby, we cannot detect the small or large bowel. But regarding the clinical history of the examiner, less than 1 month and present with vomiting, we should give different diagnosis, small bowel malrotation with volvulus. So next step, I would like to recommend to do upper GI contrast, not lower GI. When he give you upper GI contrast, there is mid-gut malrotation, abnormal position of jejunal junction, a corkscrew appearance of the jejunum and the proximal jejunum. So this case of mid-gut malrotation and mid-gut volvulus. Take care of the age and take care of the clinical history of the examiner. He will give you and age of the patient. Don't forget the foramen magnum. It's very common to give you a case with foramen magnum, maybe obliterated foramen magnum due to Chiari, maybe stenosis. This case there is stenosis. Only stenosis of foramen magnum cause compression in the cervicomedullary junction with abnormal high signal. First possibility achondroplasia. So I would like to assess the X-ray spine to assess the other finding of achondroplasia. This foramen magnum, take care. Maybe give you a CT or MRI brain axial image obliterated foramen magnum, maybe Chiari. So ask to see the sagittal image. In this case, no Chiari, only just narrowing and stenosis of foramen magnum. This case is achondroplasia. This common case also in the exam. There's hyperinflation of the left upper lung loop, causing mediastinal shift to the other side. The other lung appear normal, other lobe appear normal. So this case is congenital lobar emphysema, common in exam case. Congenital lobar emphysema most common affect left upper lobe, and then right middle, and then right upper. We can give different diagnosis, but less likely to be a foreign body aspiration, as foreign body will give all lung hyperinflated or affect lower lobe due to effect of gravity. But this case affects mainly the left upper loop. So this left upper loop congenital lobar emphysema, don't forget this case. This case, the emergency case, we can see here there is peritracheal soft tissue thickening, but also we can see the thumb sign. There is thickening of epiglottis causing compression on oropharynx. This is emergency case because it can be cause upper airway obstruction. So don't forget the epiglottitis, common in exam case. This case, the destruction mainly in the joint, not in the bone. Bone also affected, but more affection in the joint. There is destruction in the joint, dense bone, vascular calcification, soft tissue swelling. In case of vascular calcification like that, don't forget diabetic foot, and this case was Charcot joint. Charcot joint mainly affect the intertarsal joint, but can affect also the tarsophalangeal joint. Next step, I would like to assess by MRI to rule out any other association like osteomyelitis. Mandibular cysts are common in the exam. When we give differential diagnosis, first start by primary mandibular cyst, like dentigerous cyst, odontogenic keratocyte, adamantinoma. Then we can add other different diagnoses like simple cyst, aneurysmal bone cyst, but don't forget mandibular cyst. In this case, we cannot see floating tooth or floating teeth. There's only multiple unilocular cyst. No evidence of multiple septation, no subbabble appearance. So we can add different diagnosis, odontogenic keratocyte, especially multiple cyst and unilocular. If the examiner gives you history, the patient has skin lesion or falx calcification, don't forget Gorlin syndrome. There's other cases also I would like to share with you. Regarding the MRI, don't forget to look to diffusion and SWI. This patient present with headache. We can see here There's lesion subcortical mixed signal, high and low signal. Inferior with image. In T2 also. The key finding here, when we see the gradient, the lesion is low signal, causing blooming artifact, and the related line of low signal reaching cerebral cortex. It was hemorrhagic venous infarction secondary to cortical vein thrombosis. In case of MRI brain, don't forget to look all sequence. Ask to see the diffusion, ask to see gradient. In case of mixed signal like here, T2 has mixed high and low signal. Don't forget it could be hematoma or hemorrhage, so better to look all sequence. This case also common in the exam. This banana-shaped uterus and only one fallopian tube. Regarding this image, first possibility is unicorn uterus. We would like to do MRI to rule out any rudimentary horn, maybe associated with non-communicating rudimentary horn and not appear in the history. So it's common also in the exam, banana-shaped uterus with only draining one tube and non-visualized other uterine horn and other tubes. So top diagnosis is unicorn uterus. I would like to confirm by doing MRI. This case, don't forget any tubular opacity in the chest X-ray or CT with distal air trapping like here. We put different diagnosis is bronchial atresia. We can confirm the finding, ask about the coronal and sagittal. We can see here this tubular opacity related to the bronchi with air trapping distally. So this case is bronchial atresia, which is common finding also associated with air trapping. This most common case, the candidate missed it. I would like to review with you some tips and tricks regarding the VIVA exam. Better when you see the case, start by spot the abnormality and start to describe it. Give your diagnosis or differential diagnosis. Next step and management. Try to finish within 2 minutes. Don't lose time because the time is very important to see more cases. Try to close the case without help. Try to close the case without examiner tell you anything. Close the case by yourself. Description, then diagnosis, different diagnosis, next step and management. Most of the cases are easy. Just speak and close it. In case of long cases and VIVA cases, some tips should you know. In the brain, don't forget to rule out any venous thrombosis, any arterial thrombosis because it's an emergency case. If there is mass, don't forget to speak about mass herniation, brain herniation, tonsillar herniation. Any brain herniation, look to any sign of brain herniation. If there is hydrocephalus and CSF herniation, don't forget to, it's an emergency case to insert ventriculoperitoneal shunt. Don't forget dense artery sign and basilar artery, dense basilar artery, don't forget to lick it. If there's case of stroke, ask to see a stroke window. If he asks how stroke window, width 8 and the length 32. If there is case of hemorrhage, ask to see a subdural window about 150 width and 75 length. Maybe the examiner asks you. This regarding the brain. In the chest طبعا cases don't forget to rule out any pneumothorax, pneumodiastema, tension pneumothorax because all this emergency case. Don't forget if there is abdominal CT, look in the chest to rule out any pulmonary embolism, especially if there is neoplasm, because there is paraneoplastic syndrome. Maybe there is neoplasm in abdomen associated with pulmonary embolism in the chest. Look to lower cut of the chest to rule out pulmonary embolism. In cases of chest, look well to all line and the tube and be sure about there is good position. Look to the periphery of the film even in the X-ray. Take care of the periphery of any film. Go to systematic. If you can see any the finding or spot the abnormality, go systematic, and you should have checklist, mainly in the rapid reporting, mainly in the long case, in Viva. You cannot see any abnormality, go to checklist. In the abdomen X-ray, rule out any free air, rule out calcification, soft tissue shadow, like that. Bone, paravertebral shadow, the periphery of the film. Don't lose all this finding. In the abdomen also, don't forget to assess the superior mesenteric eccentric vein, vascular thrombosis or ischemic bowel disease, sign of pneumoperitoneum, take care of regular sign, falciform sign, football sign, all sign of emergency is the abdomen. I think I review all cases. And regarding the rapid reporting, try to finish all 30 cases in about 15 minutes, and then repeat it again. If we get 15 or 16 case abnormal, inshallah, you will pass. 16 case enough to be abnormal, but me should be sure about this. Don't overcall the finding, and try to finish it. Try to from now until the exam to solve 3 or 5 sets every day. I think everything I inform you about it. Emergency case is very important. In any emergency case, طبعا inform the examiner it's an emergency case. I would like to pick up the phone and inform the referring physician quickly. Nothing more than that. The exam, inshallah, will be easy, and all of you will pass, inshallah. Any question? Hello?
الو السلام عليكم.
عليكم السلام.
كنت بسأل حضرتك بس how many cases the maximum cases of abnormal in a short exam?
In rapid
How many
reporting?
cases yes, what about the maximal or the maximum number
I
of
think
abnormal cases?
16, يعني maybe 16, 17 abnormal. 16. If you get 16 cases, it's okay. Inshallah, you will pass.
And 15?
Better 16.
This is routine, دكتورة.
Range. يعني it can be from 15 to 17 abnormal.
Okay,
If you
thank
give 16, so it's okay, خلاص, inshallah, you will pass. Yeah, but if you see 15 and nothing, خلاص, maybe 15. Usually 16. 16 abnormal and 14 normal.
يعني it can range from 15 to 17 from the exam side?
Yes, abnormal.
Okay, thank you.
Try to try to solve the exam 2 times. Finish first round within 10 or 15 minutes, then look again. And don't overcall the abnormality.
Okay, thank you, دكتورة ولاء.
Thank you, Dr.
دكتورة ريهام.
أيوة.
Okay. Let's make any questions at the end of the session, please. You have the microphone, دكتورة ريهام.
Okay, hello. First of all, good luck inshallah. بصراحة all the candidates did their best and you never wasted your time وكان الأداء بتاعكم أكتر من رائع يا جماعة. I want but to assure you, you are doing your best actually, you are perfect and you have settled your checklist. Just don't panic in order to make use of this checklist. For me, I will talk only about one case. Maybe this case, not all the people, maybe only 1 or 2 candidates got it. And it has too many things to say. And again, it is related to the woman imaging, but this time it is on the CT level. Whenever they tell you, first thing, whenever you listen to the history, please focus, is it a female or not? Because in the woman, we usually think about inflammatory process related to the female, or it is related to the endometrioma and the adenomyosis. This is another checklist that we have to recognize whenever they say that this is a female. This is number 1, even in the GIT cases. Whenever they say the female, just remember that we have to add few points in our differential diagnosis list. First thing, when you see any CT, don't go directly and say that there is an intestinal obstruction. First thing, whenever you see the bowel dilated, just go downwards in order to check, is it an intestinal obstruction or this is an interior study? It tells a lot, okay? How can I tell? Just the presence of the Foley's catheter downwards mean that this Foley's catheter, this means we are in interior. So never over-call it and say that this is an intestinal obstruction. This is number one. Second thing, you have to mention either this is contrast, non-contrast, is it arterial or portal, or if you totally miss the point, just tell them that this is an enhanced study. But once the vessels is too much enhancing, more than the arterial is much more enhancing than the portal veins, then it is an arterial. And whenever they show you an arterial case, they are likely to tell you there is an active, there is a pseudoaneurysm, or there is an abnormal peritoneal or capsular enhancement of the liver, or the peritoneal reflections, or there is a pathology with the pancreas. These are the reasons why they can start with an arterial phase. Otherwise, they will go for the venous phase in order to recognize what's the pathology. So whenever this is an arterial, it gives you a clue for 4 main differential diagnoses. So don't miss it. Third thing, whenever you see this abnormality, okay, you have identified that we are in an interior, so not overcalling, this is an intestinal obstruction. You have identified that we are in a vascular, so check the vascular tree, this is very important. Third thing, after this, just check the enhancement of the liver capsule and the peritoneum. In this case, it was totally missed with most of our colleagues that there is a rim of abnormal enhancement related to the liver capsule in itself. This is an abnormal enhancement related to the liver capsule, but this is not the clue. This is a consequence of the case, but it is present. If you are searching for it, you will find it. If you don't search for it, you will never find it. Then after checking the protocol of the image and why they show you this specially sequence, just start to see the fat. Whenever you are in the GIT, look for the fat. Whenever the fat is clear, it's good. Whenever the fat is not clear, this is the clue that there is a pathology. And here in this case, yes, the fat was totally unclear. Where? Here in front of the colon, here around the baracolic area, especially on the right and also on the left. But the mesentery, the mesenteric fat, or the root of the mesentery, was clear. Fat is our friend. So check for the fat. Whenever you lose your concentration and focus, just look what's wrong with the fat. Whenever there is a clear fat and a ground glass fat, then there is a pathology related to this ground glass fat. Here there was a ground glass fatty nodularity a little bit. Here again, the peritoneum is over enhancing rather than the other side. And this is another clue, but the mesentery was clear. Whenever the mesentery is clear, we are not talking about a pathology related to the peritoneal carcinomatosis or any necrosis. It is rather an inflammatory. So the inflammatory likely involves the area anterior and not the mesenteric root. And this is a clue also that we are in an inflammatory process. For the sake of the exam, most of the inflammatory processes are either a tuberculosis infection, a Crohn's infection, diverticulitis, appendicitis, and BID. These are the 5 patterns of infection that can involve the mesentery and trick us in the exam. Here in this case also there was a linear subcapsular edematous change related to the liver. This is not an ascites. Ascites never come here. Okay, ascites is in the Morrison pouch. It extends down to the Morrison pouch. Why not? But it is rather here in this area, in the right baracolic gutter and subcapsular area of the liver. Okay, this is called the Fitzhugh-Curtis syndrome, and it is a clue for that the case was a pelvic inflammatory disease related to the woman. Another thing here in this case, that whenever you come downwards and tracing the collection that is related to the fat stranding, this collection is not continuous with the bowel loops. And that's a clue that this was an abscess. Again, going downwards, there are multiple abscesses that are not communicating with the bowel loops and with the related fat stranding. So whenever there is fat stranding, check the bowels. Are these already bowels or these are just abscesses? Again, in the GIT, check what is the study, what is the contrast, it's which phase, and whenever there is a ground glass appearance and fat stranding, just hold down and try to focus what's wrong in this area because it is likely an inflammatory process. Here, the most of the ground glass of the fat changes is being present related to the pelvis. So, and it's a female. We have congested vessels related to it. We have here a complex cyst. We have an abscess in front of the uterus. And checking backwards, there are multiple abscesses in the mesentery high up. The more involvement to the right paracolic gutter, with again here frontal abscesses related to the abdominal wall. High up again, there is a linear edema subcapsular related to the liver. So this case was a pelvic inflammatory disease and complicated with the Fitz-Hugh-Curtis. For the satisfaction of research, you will take mark whenever you say the study and label it correctly without overrating of any pathology. And you will take another mark whenever you say what is the striking finding you have picked up with your eyes, especially if it was fat stranding. Sometimes the case ends only by just an appendicitis epiploica. It could be. Why not? Okay, so the fat is very important to assess, and they want to see you that you recognize it in a case of a CT. Third thing, after you identify the pathology that picked up your eyes, just go for the cause. Try to search for the cause. What causes an inflammation of the peritoneum? It can be something spontaneous, so check the liver is cirrhotic or not. That's called a spontaneous bacterial peritonitis. It involves people with cirrhosis, or it could be infection like tuberculosis infection, which is a very common complication of which. Then, in order to ignore it, just to check this ileocecal junction or ileocecal valve. If it's hypertrophied and edematous, then it is likely tuberculosis. It could be Crohn's, why not? But the ileum is fine, well and good. Check the appendix related to this area also, and the appendix was well and good. And the last thing is the presence of a diverticulitis, which wasn't the case here. There was no diverticulitis or diverticular abscess. Then the last thing, because this is a female, it is likely a pelvic inflammatory disease. And one of the stages of the pelvic inflammatory diseases is not only the presence of abscesses, but also the fibrotic bands and the changes that most of you spotted it being present here, subserosal fibrosis that causes traction in the pelvic fat. And this is one of the marks that the disease is deteriorating and going to be severe. For the satisfaction of search, you have to say the full complications of the disease, which is one of them is this presence of the fibrotic bands. Subserosal deposits is one of the complication. And the last thing is the subcapsular edematous changes, because it can end in, after perihepatitis, it can cause transfer hepatitis as well, and results in the formation of a hepatic inflammatory process. That's it for this case. Whenever you see an abnormality in the GIT or in any enhanced contrast study, just tell them that you would like to check it in other sequential phases of the contrast to identify better and characterize the pattern of enhancement. This is very important to tell them. You did very great. It's just the matter of persistence, and I believe in you all, and you can do it. It's easy for you as long as you are focusing and believing in yourself. So good luck for you all, and any questions, we are already together. And thanks, Redmi, for all the support. Thank you so much.
في
دكتور
حد
احمد
عنده أي أسئلة
دكتور احمد you are here دكتور احمد All Dr. Fahmi. Who will be next, Dr. Ahmed Al Hajar or Dr. Muhammad Fahmi? Who is ready?
Yes, I'm ready. I can
Okay.
take over the session.
Yeah, you can
Okay,
take.
I can share my screen.
Yes. Thank you.
Assalamu alaikum and hello everyone. And thank you for all my colleagues in RADME. They did a great job to discuss with you different tips and tricks in the exam. And I wish all you the best, inshallah. Okay, we'll start with this case. This patient comes with central chest pain. So most of the people, the comment on the chest are clear. Yes, chest is clear. They were mistaken with this one to be as a pneumomediastinum. This is pneumomediastinum. They were mistaken with this mediastinal shadow, which caused mild entrapment on the tracheal shadow, but this one was just only unfolded aortic arch. So don't forget to check the end of the or periphery of the film at the discussed to you with you. We can see here below the diaphragm distended gaseous shadow, but this is not the typical for pneumoperitoneum or continuous diaphragmatic sign, because we can see multiple lines here, which are the colonic diverticular colonic signs. So is this not a pseudo continuous diaphragmatic sign of the pneumoperitoneum? So this one is a prominent gaseous shadow, which suspected for another cause of distended or dilated bowel loops. So the rule here for the tangential radiograph has no rule. So the second step we request is the CT abdomen pelvis to check what is going wrong in the abdomen. When we did the CT abdomen pelvis, we can see here, you can see the esophagus is dilated and distended. The stomach is compressed, and we can see this one huge distended colonic shadow. Okay, we can see here the swirl sign of volvulus. So we have two differential diagnoses, whether to be cecal volvulus or sigmoid. If you are not sure which segment is dilated, so go down with the study and look for the root for that dilatation. So that dilatation goes to the root to the right side here. And in the same time, we check for the sigmoid. We can see the sigmoid here is collapsed down to the rectum. So this is not a sigmoid volvulus. This is a cecal volvulus. Okay, you can ask him in my routine practice. I can check also double check with the coronal view if you are not 100% sure. It is not a typical fetal sign of cecal volvulus. But from the coronal view, we can see here the rectum, we can see the sigmoid, and we can see all the dilatation here going to the right, left, upper side of the abdomen. So this is cecal volvulus. We can see the volvulus swirl sign. In any intestinal obstruction, we have many signs. We have to also negative, we have to mention. There's no perforation, vascularity is good. For the bowel wall, there is no ischemia. So few signs, negative signs, you have to comment in the any intestinal obstruction. We go to another case. This one comes with acute abdomen. So very common case to have the pancreatitis. We have this pleural effusion, basal consolidation, fatty liver. We have this nasogastric tube, but sorry, wait, don't forget this extended to the jejunal tube. So this is a nasojejunal tube, NJ tube, not nasogastric tube. We have this dilated small bowel. Also, as Dr. Ham said, don't forget rapidly say this is a small intestinal obstruction. Just with this, you say there is small bowel dilatation, bowel vascularity is maintained, there is no evidence of perforation. Okay, we'll try to see the site of obstruction, but there is no definite site of obstruction. Okay, we go back, there is free fluid in the abdomen. And in the upper abdomen, the main fluid seen around the pancreas. As we can see here, the main fluid seen around the pancreas is extended to the left hypochondrium. So this is the case of pancreatitis. In any case of pancreatitis, also we have negative signs we have to comment. Is it necrotizing pancreatitis? Is it hemorrhagic? This is not definite necrotizing, but alien necrosis happens here in the tail, sorry, and the tail and the body of the pancreas. Okay, so there is not hemorrhagic, no emphysematous signs. Okay, we can see multiple hyperdense spots within the head of pancreas. So those are multiple stones that may be the cause of the pancreatitis. In the pancreatitis, we have to exclude other signs for the vascularity. Any other vascular compromise here, pseudoaneurysm, thrombosis, or any perforation or any active bleed, there's no sign of vascular compromise. Okay, in that case, the patient had treated with as a pancreatitis, then came after 2 weeks with another episode of acute abdomen. Okay, when you get a follow-up scan, so that means there is a specific sign he needs you to pick up and pop that sign straight away to complete and finish the case. Okay, once we see this one, we see yes, this patient complicated with pneumoperitoneum. It's an emergency case, surgical emergency of perforated vesicles for that patient. And I have to inform red flag or write the emergency code or whatever. I have emergency contact the surgical team for this one because this one perforated viscous and it has pneumoperitoneum. In the meanwhile, I can see or look or search for the site of perforation. We can see this one is a very clear duodenal perforation. And also in the meanwhile, there is worsening picture of pancreatitis. Now we can see the definite necrotizing pancreatitis in that case, and the collection was more loculated, maybe because of hemorrhagic or maybe because of secondary bacterial infection. So once I give you a follow-up sign that follow-up case, that means that this definite or specific sign need to pick up to complete the case in a safe way. We'll move to another case. Okay, this one also comes with acute upper abdomen. We can see multiple cysts in the liver. We can see gallbladder is distended, has mild thickened wall, multiple small dense calculus gallbladder, and okay, we go down, we don't see much significant in the abdomen. Many of your candidates has mistaken with this case with the mesenteric paniculitis, but this is not a case for the FRCR exam. So don't be mistaken or panic with the case of mesenteric paniculitis, an acute case. Okay, so we go up again. We don't see any other abnormality or significant finding within the abdomen except for this calculus gallbladder. Okay, if there is calculus gallbladder, that means it's not simple calculus gallbladder. There is a sign of thick wall and mild fat stranding around the gallbladder. Is a calculus cholecystitis. Okay, there is no emphysematous signs of the gallbladder. Okay, once there is calculus gallbladder, I have to check for the complications of the gallbladder stones. What does it mean? That means I have to look and search for any dropped stones or dislodge within the CBD or not. So I have to trace the CBD down and look for any missed stones. Okay, what is this? Wow, we can see multiple stones down within the lower end distal CBD. Okay, that means if there is a CBD stones, potential complications I have to rule out. First of all, pancreatitis. Okay, do we have any signs of pancreatitis here? No, there is no pancreatitis here. Second thing is ascending cholangitis. If we can see properly, we can see the fat stranding mainly within the porta hepatis region. The wall of the CBD and cystic duct are thickened and enhanced. So this is a complicated calculus cholecystitis complicated with ascending cholangitis and cholelithiasis. If we look for the coronal view, we can see this more clear. we have this gallbladder. You can see mild fat stranding around gallbladder. The gallbladder wall is thickened, and in the coronary view, we can see multiple stones within the distal CBD. We can see the CBD wall is thickened and enhanced, even though the cystic duct is thickened and enhanced. So this one is a cholecystite, calculus cholecystitis, choledocholitis, complicated with ascending cholangitis. So we have to look for the LFTs and urgently refer for MRCP and a surgical assessment. Last case regarding the intestinal obstruction and the potential complications for bowel ischemia. This patient had a history of bowel surgery and a colostomy on the left side and came with abdominal pain and vomiting. So first of all, as I told you, any case of intestinal obstruction, we have to look for two main signs: the vascularity of the bowel wall and the evidence of perforation. As you see here, I have NG tube and abdominal free fluid. We can see pancreas is normal. He has a history of colostomy. Let's go to the below. Yes, we can see colostomy in the left iliac fossa, and we can see here also a site of volvulus, as you can see. So this is the volvulus of small bowel. This is not parastomal hernia or obstruction at the stomal side. The parastomal, the stoma hernial orifice is wide, so there's not a site of obstruction of the small bowel. The small bowel obstructed because of the volvulus here, and we can see here some bowel wall is dilated, wall is thickened, significant fluid, and the vascularity is hypoattenuating. The wall is hypoattenuating. If you compare this segment of vascularity in this bowel and that segment, you can see the difference. So most important thing when there is small bowel obstruction or large bowel obstruction, you have to comment on the vascularity of the small bowel or the bowel, and if there is an evidence of perforation or not. There is no evidence of perforation because there is no pneumoperitoneum, but a significant bowel ischemia. And bowel ischemia is very highly emergency in UK because the operating theater can open for the bowel ischemia, but in some obstruction is not that emergency. Once the surgeon there will have bowel ischemia, the operating room should be open for him. Okay, all the best. I wish you all the best and good luck for everyone. Thank you.
Thank you, Dr. Muhammad Fahmi, our best friend here. We have Dr.
Thank you.
Ismail. We have Dr. Ismail, the famous, the great Dr. Ismail. If he is ready, he can join us.
One minute, Dr. Mahmoud, inshallah. 1 minute.
Okay, take your time. I will entertain them. How was the last week before the exam? What kind of plays you are playing in this last week? Don't tell me that you are still revising and doing some exams. Should take a break and take some rest before the real exam. Wish you all the best. Enjoy the journey, not terrified from the journey. He will continue it. Dr. Ismail is a brilliant teacher, really. He will continue it. But you know, sometimes there is disturbance in the planning.
Okay, I will share, Dr. Mahmoud.
Yes.
Is my screen?
Yeah.
Okay.
Everything is ready.
Okay. Thank you,
Okay.
يا boss.
خلاص.
السلام عليكم. I'm your friend Ismail Sayed. I want to just revise small points about safety. Safety issue is the most important point in the exam because if you failed one of these cases, just one, you will fail with the two examiners. Whatever you did in the rest of cases, even if you scored 8 marks or 7 marks in 10 cases and you failed one of these, everything will be gone. So please, 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 safety in pediatric chest radiograph. According to time, I will extend to some elbow radiograph as well. We have 4 points to concentrate on pediatric chest radiograph. One of them is emergency chest. The other one, emergency abdomen. Then emergency bones, and finally lines and the tubes. Some of us prefer to start with lines and the tubes because they forget them. No problem. For example, this case we brought before, we have here endotracheal tube in position. Sometimes endotracheal tube displaced down and causing lung collapse or lobar collapse, and is considered emergency for repositioning. Nasogastric tube, it's step below the end of the chest radiograph. So I need abdominal radiograph to comment about its location. We have 2 vascular radiographs and sometimes 3. One of them may be peripherally inserted catheter, which is not our case, sometimes misplaced. One is arterial, the umbilical arterial catheter and umbilical venous catheter. This catheter is malpositioned, lower down. If not in optimum position and we try to inject IV fluids, it may cause hemorrhage inside the liver. So this is also emergency, misplaced lines and the tubes. This is a final or the first point according to your scheme. But you must comment on lines and the tubes in every radiograph, every pediatric radiograph, chest or abdomen or even skull or skeletal. Okay, emergency chest. What should I look for in emergency chest? Look at this film. Oh, there is respiratory distress syndrome. It is not emergency, just pathology. The emergency is air leakage. If there is pneumothorax, pneumomediastinum. So take care about variable appearances of pneumothorax. Pneumothorax may be very easy to diagnose, like this one, apical pneumothorax, or also this one, very easy also. This is deep sulcus sign. Although these radiographs are relatively common in practice, not in the exam. In the exam, you may see subtle finding, like look at this cardiac border. The cardiac border is hardly defined. This is the usual situation in most of kids. But look at this border, sharply defined. Look at this extra lucency at lung basis. Sometimes you see bronchovascular marking, like in this case, but extended or exaggerated lucency. These are indirect signs of pediatric or neonatal pneumothorax. So pneumothorax has many phases. And of course, pneumomediastinum is easier to catch, usually Spinnaker cell sign. But the more common in exam, whether viva or rapid reporting, pneumothorax. Okay, so this is the first point to take care. The second one is neonatal or abdomen in the chest radiograph. Most of us, unfortunately, ignore this part. No, you have to concentrate very well. What should I look for? Look at the abdominal wall. First, the abdominal wall, then compare with the liver shadow. Like this case, this normal abdomen. Abdominal wall similar to density of liver shadow, similar to density of expected splenic shadow. Upper abdomen, all are right. Unlike this case, this is the abdominal wall bright, but the rest of abdomen loosened. I can see here, oh, this is falciform ligament sign, and the lucency continued here. This is massive pneumothorax. And by the way, missed from most of you in the Viva exam I did. Most of you missed this part because you concentrated on the chest and good point, lines and tubes, and you missed this. This is safety. This is one of the most important safety issues. Pneumoperitoneum. Concentrate on this item. And if you see a pneumoperitoneum on the first look, say it. Don't comment on a small sized chest and preterm. And no, there is massive pneumoperitoneum manifested as lucency overlying the whole abdominal, the whole visualized part of upper abdomen. This is a high emergency. I should pick up the phone and inform the clinician. Then I will continue the rest of the film. Some examiners, I think, will change the film immediately after you catch this point. Another point important to catch in the upper abdomen, if there is any air lucencies, branching lucencies overlying the liver, impressive of portal venous gas. So pneumoperitoneum or portal venous gas. What about if dilated bowel loops? Dilated bowel loops, if you see, is not a serious problem, but maybe underlying problem of perinatology, like necrotizing enterocolitis, early phase of necrotizing enterocolitis. So the next
محاولة تصل عن طريق
ميوت
يبحث عن
دكتور محمود.
فإذا المحاولة إلى كوفاسيتش لا زالت مستمرة وقائمة. الكرة تصل إلى
There is a match, I think, with Manchester City is going.
متبقية قبل نهاية إحداث الوقت.
Okay, thank you. Okay, back again. So lines and the tubes, emergency chest, pneumothorax, pneumomediastinum, emergency abdomen, pneumoperitoneum, portal venous gas. If dilated bowel loops, you may be asked about, for example, how to follow this case, how to follow up. If you are following a chest problem like this one, respiratory distress syndrome, you may follow every 24 hours. But if you are following abdominal problem, just 8 hours, because you are afraid of perforation. Okay, so the first item, lines and the tubes, abdomen, emergency chest, emergency abdomen, emergency bones. Please do not forget bones. I know maybe chest problem is obvious or misplaced lines and the tubes. Comment on the bones. Which bone is important? Posterior rib. Posterior ribs may be the safety issue in this radiograph. Look here at the posterior ribs, normal, but here, oh, bulky. This is callus. Callus in this age group in posterior ribs, child abuse. This is a very, very, very important issue. Also, if there is fracture humerus, uncommon in this age, also a sign of child abuse. Ask for skeletal survey and child protective survey complete to finalize the case. But if you see just fracture one of the clavicles, no problem. Just mention this point. If isolated bony fracture, it may be a sign of birth injury. So we have 4 emergencies in this chest, neonatal chest radiograph. Emergency chest, pneumothorax, different phases, pneumomediastinum, emergency abdomen, pneumoperitoneum, or portal venous gas, or just dilated bowel loops. Dilated bowel loops may be an early sign of necrotizing enterocolitis, which may end in perforation later on and fatality. Emergency bones, the posterior ribs, and the visualized part of humerus on each side, and lines and tubes. I think I have more few minutes, so I'll talk about in brief elbow injuries in children. Also an important safety radiograph. We have 5 or let's say four common injuries. The fifth one is the most constant finding, elbow effusion. This slide is important for Viva and important for rapid reporting. Very important in both of them. Elbow fusion is a common sign of injuries in pediatric age group. Will be manifested as elevation of the anterior fat pad or appearance of the posterior fat pad. What are the common underlying injuries? The most common one, supracondylar fracture. Okay, followed by elbow dislocation. Why you ignored these 2 fracture? I'll tell you in a minute. Supracondylar fracture may be not so clear, but you can diagnose it by lines like anterior humeral line, which may miss the capitellum. Okay, so it may be indirect sign of supracondylar fracture. Elbow dislocation also manifested by abnormal line, iridiocapitellar line missed the capitellum. So this is an indirect sign of pathology, supracondylar fracture, which is very common. And this also an indirect sign of elbow dislocation, both if misdiagnosed may end in permanent deformity. So it's very important to diagnose. The remaining 2 fractures, medial epicondyle avulsion fracture and lateral condyle. Very, very important in the exam setting to mention the arrangement, the order of appearance of ossification centers. In Arabic, we call it karam tool. In English, crito. Capitellum, radial head, and medial epicondyle, and so on. But here is lateral epicondyle. Lateral epicondyle is the last one. I can see here faint lucency. You may consider this as normal, but look here. Olecranon process is not appeared yet. So this is a fracture. Lateral condyle fracture, because the epicondyle is didn't appear yet. So this is lateral condyle fracture. It's a relatively common fracture after supracondylar and medial epicondyle avulsion. So lateral condyle fracture may be diagnosed by revising the ossification centers and also soft tissues. Look here, this is muscle and this is subcutaneous fat. But here on the opposite side, oh, soft tissue edema. It denotes there is injury on the lateral or radial aspect. This is a lateral condyle fracture. And also medial epicondyle avulsion fracture diagnosed also by arranging of the centers. Radial head and capitellum, medial epicondyle before olecranon. But here I see olecranon, no medial epicondyle. Most likely it's avulsion and entrapment. And also look at soft tissue here and soft tissue here, another indirect sign. So please revise the elbow injuries in children. It's a safety issue, and pediatric chest radiograph and pediatric abdomen radiograph and the pediatric skeletal all are considered safety radiographs in the exam. I hope you best of luck. Assalamu alaikum.
No, please, Dr. Ismail, don't leave us.
Thank you.
Welcome.
Thank you, Dr. Ismail. Wallahi. Thank you so much.
Welcome, thank you.
Many beautiful tips and tricks from
Thank
all
you.
our contributing examiners and lecturers
Thank
today.
you.
And many Viva tips today they mentioned, and very and clearly very important in the exam. And let's talk about that it's Viva is one of the most tough exams in the world in radiology, and everyone struggling that exam. And the nice in this group of our contributors today from Middle East, all of them have very beautiful experience, and they give you like the the most clear tips after all the experience through the past, and you take it in like they say يعني على طبق من ذهب بالعربي. Okay, so you take it in very nice mood. The most important, as you see through all the tips they mention, the emergency and the safety. So even if you try to struggle with yourself, the most important focus in 2B exam, this main two issues, the safety and the emergency. If you can pass these two issues and you prepare well for that module, in that way of studying that modules, in the way that you can pass the cases, it is very easy to pass the exam. Most of who fail in this exam, the reason is, as you see, it is safety, most safety and emergency cases. So if you can, inshallah, through your preparation, focus in that two issues, and also the confidence. You have to act like a consultant in the exam. Be relaxed. This is not easy. You always be stressful. You don't sleep well. This is the usual situation. But try to train, exercise, do your best to reach this point. And before all this, you have to, inshallah, take a good intention for what you do, why you want to do FRCR. This is a good question you have to answer in yourself. I hope everyone doing well and have a good night and good evening for all of you, and sleep well. Inshallah, we have another free activity soon. See you there, inshallah. Enjoy your time and have a nice time. Assalamu alaikum.
الو الو